Okay, we are back. This is Senate Health and Welfare on April 5th, and we're taking up H266, an act relating to health insurance coverage for hearing aids. We have three folks here to testify. We have looked at the bill previously, so this is an opportunity to understand further what we're all about. So thank you for being here. Ruby Baker of Code, do you want to introduce yourself? Are you going and provide your testimony?
Thank you for having me here today, and lovely to see all your little tiny selves on my screen. My name is Ruby Baker. I am the Executive Director of the Community of Vermont Elders, and I'm here today speaking on behalf of the Hear Hear Vermont Coalition, which is a coalition of over 20 organizations and individuals that has been seeking for a long time, though I am a new addition, to ensure comprehensive insurance coverage for hearing loss services and hearing aids for Vermonters who need them. As many of you know, this bill and this issue has been in front of you for decades and has been stuck on the wall for decades. So the time is right, and we are asking for you to pass this bill. I want to walk through a few things, and I'm going to share some numbers that I pulled out of Nolan Langweil's testimony in House Healthcare, and personally, I found his chart to be incredibly helpful. So if you want to view that, you're welcome to. But I'm just pulling out the population numbers that he shared for different insurance groups and then applying them to my testimony. So that's where those numbers come from. Currently, H266 does three really important things, and so I want to acknowledge what's good and strong about the bill. It acknowledges the work that is currently happening through the Essential Health Benefit Update process. And this committee and the House Healthcare Committee last year required that work to start, and the bill requires a report back on how that's going. The result of the actuarial analysis, stakeholder meetings, and the committee work were so incredibly powerful, both to the working group and also to the people, the grassroots advocates who have been working on this for so long to really have a say and to be heard. So I want to acknowledge and thank EFR for their excellent facilitation of that work over the summer. As a broad group, we were able to explore the Medicaid coverage and determine that it is really quite good. So there are some issues sometimes for individuals with access. So I'll acknowledge those. But the coverage as written is good coverage and model coverage that should be included in the essential health benefit. Wakely, the actuarial firm, shared not only that the cost was quite low, it's between 40 and 60 cents per member per month, but also that difference in cost between medical necessity and one hearing aid per year every 3 years is negligible and offers significant benefits and reduced administrative burden in cases where somebody needs care a little earlier. So this helped us really formulate our thinking and our support for medical necessity as the phrasing that we wanted to make sure stayed in the bill, because it really provides that opportunity without burden of prior authorization and without having to fight for your needs to be met. So that's really important to us. At this point, that process is moving forward, and any changes now would potentially slow or stop that process. So I want to acknowledge that it's good, it's moving forward, and we would advocate for not making any changes at this point in time. The essential health benefit applies to the small and individual market, and that's roughly 67,000 people. The bill also codifies under Medicaid that codifies coverage under Medicaid. We have heard from individuals that accessing that coverage can be challenging for adults, but and so by writing this down and making sure that Medicaid has to cover it, it actually increases access to the appeals decisions and protections of that process. So it's very important to keep the Medicaid language in there. And that applies to roughly 140,000 people in Vermont. And the third thing the bill does is establishes coverage in the large group market. The coverage is good. We use the medical necessity language. That is really important. If your doctor says you need it and you need it now, you should be able to get it. And actually the testimony that you heard from Diva last week suggested that they are also exploring that medical necessity issue to reduce administrative burden on the providers and improve access for those who need care. And that large group market is roughly another 17,000 people. What H266 doesn't do currently, and this is where we are advocating for an additional group of people, there are two specific populations that have been carved out, even though the state has the authority and ability to regulate coverage. That means that those people have been specifically excluded from coverage under this bill. Those two populations are the state employees and the teachers. And the argument I've heard is that these groups have negotiated their own coverage already and that we don't need to do anything. And I will say they may have negotiated that coverage, but what we're hearing from the state employees plan, at least, is that they are offering $1,500 per year every 60 months, which is 5 years. That's not equitable. In fact, price caps were disallowed under the Affordable Care Act for ACA plans because they disproportionately harm those with the greatest need. These two groups account for roughly 60,000 people, and we are asking that you include them in this bill to ensure as much continuity of coverage, access to care, and healthcare stability for people as possible. We understand that people move jobs, and someone shouldn't have to be afraid of losing their hearing coverage, their hearing healthcare coverage, because they want to work for the state. They want to become a teacher. 23% of Americans age 12 and older have hearing loss. That's nationally. And is an average where the prevalence of hearing loss increases with increasing age. So for Vermont, a state with a higher than average age, we also have a higher population prevalence of hearing loss. Almost a quarter of Vermonters may suffer from hearing loss. Just taking those numbers I threw at you a minute, a little back of the napkin, we're talking about roughly, H266 covers roughly 224,000 people, which means that as many as 55,000 of those people may suffer from hearing loss and would be covered by this bill. We are asking you to remove the carve-outs that exclude teachers and exclude state employees and ensure coverage to the roughly 60,000 additional Vermonters in those two groups, 15,000 of whom may have hearing loss. This is not just an equity issue. This is a population health issue. State statistics in Vermont show us that in 2018, 142 Vermonters died as a result of falling. This is more than double the national average. Vermont has the 18th highest rate of suicide in the United States. Vermont also has the 6th highest Alzheimer's death rate in America. According to the CDC, social isolation significantly increases a person's risk of premature death from all causes, a risk that may rival those of smoking, obesity, and physical inactivity. Why am I sharing this? Untreated hearing loss is directly linked to increased risk for mental health challenges, loneliness, and isolation. Studies suggest that the risk of developing dementia doubles for older adults with untreated mild hearing loss. And for those with severe hearing loss, the risk is 5 times that of a person who does not suffer hearing loss. a person with a 25 decibel hearing loss, which is considered mild, is 3 times more likely to have a history of falling. And the risk increases by 1.4 times for every additional 10 decibels of hearing loss. Hearing is critical to a person's ability to access important health and emergency communication, safety features, and other access to care. Hearing is a part of population health. And I'm going to end with some personal stories. In 2020, this coalition created a petition to gauge and build support for H266. And in that time, over 2,000 Vermonters from every corner of the state have signed on to share their support and their personal stories. And I wanted to share a few with you. Ms. Eldred from Burlington says, I have substantial hearing loss. It affects almost every aspect of my life. It makes my job of working remotely and hearing on phone calls difficult. And also when I was working in the office, to understand what the students and professors were trying to communicate to me. I feel if it gets any worse, I may no longer be able to work. It is embarrassing to not be able to afford hearing aids. It is distressing and isolating to not be able to hear. My ears and hearing are a part of my body and need this coverage. Deborah Richtner from Moncton says, I have had hearing loss all my life. The only reason I am able to finally wear hearing aids is because my sister-in-law gifted me my brother-in-law's hearing aids after he passed away. They are older and obsolete, but they work and have greatly improved my life. It is truly sad that the only way I can afford to wear hearing aids is to inherit them. Michael Moreland from Plainfield says, I had the fortune of having my last hearing aids covered by my insurance in Texas. Since I've moved to Vermont, I wish for the same level of coverage. Karen Rocco from Salisbury says, my hearing loss was first diagnosed when I was 15 and studying Chinese in college. By that time, it was severe to profound. If the sophisticated hearing aids of today had been available then, my life would have been far easier. As I went on to pursue a doctorate at Harvard, it has been a mystery for many years why cochlear implants, which cost so much more than hearing aids, have been covered by health insurance, whereas hearing aids have not. I'm going to send you my testimony because there are more stories that I would like to share, but I don't want to take up too much of your time. But I would just urge you to consider the many, many, many people in Vermont who need coverage in order to be safe, in order to live good, healthy, productive lives, and who, in order to engage in the world. And we ask that you remove the carve out for teachers and state employees to ensure that they also receive this coverage. And we ask that you pass H266.
Ruby, thank you very much. And we look forward to having your testimony in writing on our webpage. It's got a lot of data in it that is extremely helpful. And so I'll open it up for questions at this point. But I'm going to just ask one, and that is we have not heard from the NEA or the VSA, unless I could stand to be corrected on that they would like for us to undo the carve out, understanding that there are negotiations that do happen. So I don't know whether you have other information that we don't have at this point.
I don't have information about whether the union itself wishes to undo the carve out. What I did hear from just a private conversation was that if the state legislated this, they would cover it rather than having to negotiate it at the negotiating table. So in some ways, it makes, well, I would say in some ways it makes life easier, but I don't want to speak on behalf of them. I recognize that there are challenges.
Yeah, no, very much appreciate your comments. That's very helpful. Thank you. Committee, other questions?
Jen a question about that, or do we want
Hold on to that.
Okay.
We'll bring Jen up and we'll look at it in a minute. Good, yeah, because I had a question for her on that too. It's good.
Okay.
All right, so let's move on to Rebecca Chalmers. Rebecca, thank you for being here, and I know you have been a strong advocate for the expansion of hearing aid coverage for years, and it's been my pleasure to have worked with you over time. And we're finally at a stage where we see legislation. So thank you for being here, and we welcome your testimony.
Well, thank you so much. It's a real honor to be here. And thank you for your time. My name is Rebecca Chalmers. I am a person with hearing loss. I'm always told to speak personally, but I have a harder time with that these days. I've kind of gravitated to the big picture more, but I'll try to also speak personally. So here's a close-up of the hearing aid. Ooh, bright blue. I finally realized it was better to let everybody know I have hearing loss. It was less embarrassing that way than to pretend I didn't. But many people with hearing loss are closeted. Many people with hearing loss don't know they have hearing loss. One scientific study was done that showed adults were unable to accurately detect their own hearing loss. And that kind of makes sense to me. I feel like, we're not expected to self-diagnose all of our other medical conditions, so we shouldn't feel like we have to accurately self-diagnose this medical situation either. And so I am happy that this bill does include services as well, like hearing detection, hearing tests. That is an important part of it. Another personal bit is I'm also a parent of a child who has hearing loss, and that's really when I decided I needed to try to give back to the community, spend lots of volunteer time, and make the world a better place for children with hearing loss, adults with hearing loss, everybody of every age. And so I've been inspired, and my child's almost 10 now. And early years, we had somebody come visit our house who gave us a remote microphone so that my child's teacher could wear them in preschool. And so then she would be able to hear what the teachers were saying, because it turns out hearing aids are only really good for up to 6 feet distance, which is something people don't tend to realize unless you have a professional tell you. And so here's one of my remote microphones. It's like 2 inches by 1 inch and a half inch. And I'm using it. It pairs with my hearing aids, and it goes to this little thing I stick in the computer USB port so I can actually hear everybody today. So it has a lot of really important uses. And as well as I give it to people who are speaking, so I can hear them from a distance, or I can hear in noisy situations. So I just want to throw that out there. There's a variety of hearing devices these days, and the hearing aids are just kind of the foundation. We need access to the foundation, but there is more. They don't work absolutely perfectly, but they do help a ton. So I'm trying to be here today to speak on behalf of many people with hearing loss, and we're all going to be profoundly impacted by the work you choose to do on this bill. And so we're really, really, really pleased that your committee is giving full consideration to all the details in this bill. Thank you. Hearing loss, like many disabilities, is invisible. And so it tends to be unduly minimized. And I think that's really been the crux of the issue over the years. People think, oh, it's not a real disability. It doesn't really matter that you don't have health care. Well, it does. And I want to make it clear that people who use hearing aids meet the federal ADA definition and also the Section 504 of the Rehabilitation Act definition of disability. People with hearing loss have a physical impairment, which substantially limits one or more major life activities. Hearing is a major life activity. There's a federal fact sheet I can send you along with my testimony that says it right there. Also, people with hearing aids are perceived as having a disability, which I think many people know intuitively, especially folks who've been hard of hearing for an average of 7 years before they get hearing aids. part of that reluctance is they know they're going to be identified as a disabled person. And when you do that, your social status goes down in our culture, right? So, and there's also been studies that were done. I can send you that too. They showed pictures of a kid with hearing aids and without, and an adult with and without, and they had adults and kids looking at the images, and they ranked like how smart or friendly or capable the person was just based on looking at the picture. And they really ranked people wearing the hearing aids a lot lower. That's kind of an example of the perception of disability. Anyway, I mentioned that because that's another one of the ADA definitions. So there are a number of different ways that we are officially disabled. This is the Disability Equity Bill. And I say that, but I also want to mention the honor that many people choose to not self-identify as disabled, and that's okay. Many people prefer to be called a person with hearing loss or hard of hearing. And also some people who use hearing aids may identify as deaf or deafblind. The majority are likely to identify as hard of hearing or with hearing loss. And it's okay. You can self-identify how you want to self-identify and still meet ADA and other definitions of disabled. So I'm going to talk about hearing disabled, but that's not really a term most people will want to identify with, but it's the legal term. So that's why I'm mentioning it. So on behalf of my disability group, I'm really asking for full equal rights under the law for as many people as possible. And we're asking for equality, not just nice wishes or, partial things, but like actual equality. And so this bill will bring equity to people whose healthcare plans are included. And this bill does nothing for those whose plans are excluded from the bill. So my first ask is please, please, please add the teacher and state employee plans into the bill and any other plans you might have jurisdiction over. I'm not sure if there's any retiree plans that are slightly different, but please add them. And secondly, I ask you to add language to ensure that adults on Medicaid will get access to medical necessity level of hearing healthcare. And I'll talk a little bit about some of the reasons why. So there are several ways how this bill provides equity. It provides coverage at the medical necessity level. So again, I feel like I'm often talking to this kind of unspoken idea that somehow hearing disability isn't as big a deal, yada, yada. So that's kind of what I'm responding to. Hearing aids are not optional devices. Hearing testing and hearing aid maintenance services are not discretionary. These are critical. Hearing health devices and services and medical needs they're all critical to mental and physical health, to communication, to safety. Hearing aids are FDA regulated medical devices. And hearing health services are provided by medically trained and licensed providers, often who have PhD or master's level of certifications. So I'm just trying to say medical means that. It's really a medical issue, and necessity means just that. It's a need, a true bona fide medical need. So when we think of that kind of plain language, anything less than the medical necessity is just not going to meet the needs of the hearing disabled. And price caps are absolutely not adequate compared to medical necessity levels of coverage. Price caps that are in the teacher's plan and soon the state plans, they're not based on science or medicine. They're just arbitrarily selected. And furthermore, they're set at only approximately half the actual cost of average hearing aids for adults. So half covering medical expenses of just the disabled people, we're not talking about like a plan that half covers heart care and half covers knee replacements and half covers hearing aid. No, we're talking about just targeting the disabled people for getting half coverage. That is not equity. That is really not equitable. And I just really saw that coming. And I am a state employee. I got 2 people in the household who were paying for hearing aids. So after working on this like 10 some years, like, please don't carve us out and leave us with this half coverage that isn't based on medicine or science. So the strength of the bill is its medical necessity. And another strength of the bill is that there's long-term protection of disability groups. Because like for teachers and state employees, they're always renegotiating these plans. Every 2 years, they could just decide to drop hearing disabled people. And there's no legal protection in the law that I've been able to find. You can discriminate against disabled people in health in benefits plan design. So that's why we really need you to fix that loophole and make sure you include the teachers, include the state employees, and make sure that they get that continuity of coverage. I guess I'm trying to think what else. There was also, I wanted to mention too about how the bill provides equity in terms of medical necessity, but also making sure that the healthcare needs of the non-disabled are covered the same as for the hearing disabled. That's what the language is really pretty good at, I think. This bill says that the copays and coverage of all devices and services in a plan should be the same. And so that's why I was saying it's not something special, it's just an equal playing field. So if, like I was saying, if you're only going to cover like one body part to half coverage, then at least that would be equitable, right? If the hearing aid, I'm not saying that right, but I'm not quite sure how to say it. But
We understand. You said
okay.
it.
I guess I'm just trying to. I don't want to be fully excluded disabled person, but I also don't want to be like included, but only at the gimpy level where like you have to pay, 50% of stuff. Yay! That's not a yay. That's a discrimination in a slightly less potent form, but it's still a discrimination. We really want to be included and the same as everybody else, and over the long term. And also to have an access to the legal rights of appeal. So the plans that are excluded, like the teachers and the state, they don't, to my knowledge, they don't have any legal rights to appeal. But if you include them in the bill, which we're asking you to do, then my understanding is that Department of Financial Regulation will be able to oversee the appeals, and they have a standard process that they do. So here's my third ask. I'm hoping that I don't know how Medicaid handles patient and provider rights to contest failure to cover devices and services. And one of my colleagues worked at Voc Rehab many years ago, so not currently, but she said it was very difficult for her to get Medicaid to cover hearing aids for her adult patients. And so I'm just hoping if you have some capacity, could you just take a look at adding teachers and state employees, making sure the Medicaid adults get medical necessity level of coverage, and then making sure everybody's got some reasonable process for appealing if there's some kind of debate as what medical necessity is. Just making sure there's a smooth process. And then I want to touch on briefly, it's always the most vulnerable who get hurt most when they're excluded. And a few examples, like some people don't have an outer ear, so you can't hang a hearing aid on it. And so they might need a bone anchored hearing aid, which can cost a lot more. And also another example is people with the most severe hearing loss who are like functionally deaf, but rely on hearing to communicate. They really need every ounce of power that a modern hearing aid can provide, and the tinnitus and the remote microphone. And I would be in this category. Like I am functionally deaf without these. There's no hearing anybody without these. There's no, you could get by with a miracle ear. No, I need the most powerful technology. And it's the more severe or more unusual circumstances of medical conditions that are going to be harmed by just having a little price cap. So that's another reason why I want you to add those other plans in to make sure the most severe hearing loss folks and the more unusual medical situations get covered. And then, of course, also anyone who's discriminated against in other realms of their life, like people of color, women, LGBTQIA, people with multiple disabilities, they're much more likely to not have a high-paying job. And so the proportional cost of any unaddressed hearing loss healthcare is going to fall a lot worse on them, on the folks who are already marginalized. So again, it's trying to raise the tide for everybody in an equitable way. So just want to make sure everyone who has a hearing loss disability can work and as a teacher or state employee, or if they have a kid with a hearing loss, they could do that. And the essential health benefits plan large group that's already covered in this bill will have medical necessity limits to coverage. So there's no good reason to exclude these two particular plan groups, and it's very procedurally simple to add them, is my understanding. I have spoken in years past with both the State Employee Administration and the Vermont State Employee Association, and they were both like positive neutral. They said, I can't tell you anything because it's contract negotiation, but so we're officially neutral, but then they kind of give me a thumbs up. So I think it would be not a big deal to add them. And then the final kind of counter argument I want to kind of offer some ideas against would be, don't assume that Medicaid is going to be there to catch people, especially children, because I've met a number of families in Vermont who did not use Medicaid. They either didn't know about it, they were too ashamed to apply to it, or they made too much money, but according to Medicaid, but according to their own personal finances, they felt like they couldn't actually afford hearing aids for their kids. So, like, I have seen see an example here. A family that was really poor and their kid didn't have real standard brand of hearing aids and some kind of off brand, and it wasn't working well for the child. So the parent was talking with me, and I told them about Medicaid, Dr. Dinosaur, and they said, "Oh, we had no idea." And I know another family that their kid needed surgically implanted cochlear, but there's a waiting period of many months, and you're supposed to have hearing aids in that waiting period, but they felt like they couldn't afford it, so they didn't. And I know some places will give loaners, but this particular family in Vermont didn't have that experience. So they went without any hearing aids for their kid. And again, so these are all examples where having a more routine coverage is going to make a difference in a child's life. And I also know some other families who, again, they have some really poorly functioning, very old hearing aids that didn't seem to work very well. And so I'm really asking you to think about children when you're thinking about which plans to add and the quality of the bill. And let's see. And then, as Ruby mentioned, that actuarial report from the Department of Financial Regulation, it showed that the cost of adding the hearing aids is really, really tiny in healthcare terms. It's very de minimis. And I'm also, if you're interested, I could send you a whole list of different studies, scientific studies, and articles that talk about the huge return on investment. There's even one that shows insurance companies would save money by covering hearing aids because they end up with less hospital costs, for instance, like patients are hearing what's happening. So in summary, just please add all the plans you can, and please make sure adults on Medicaid also get access to medical necessity level of coverage, as children on Medicaid already do. And please make sure all plans are covered. All plans covered by the bill have reliable ways of contesting any non-coverage issues that might come up. Then I have a teeny tiny little fourth ask. You might want to consider striking the word cords from the exclusions, as I think it might just confuse matters since some hearing aids come with charging cords. So, and it's a pretty tiny little issue, and it might just be simpler to strike it. So thank you so much for your hard work on this important issue.
Rebecca, thank you so much for taking the time. And if you do have some of your testimony or specific, specific points that you have identified within the bill, if you can get that to us, that would be very helpful. We appreciate all the work that you've been doing on this over many years, and thank you for your testimony. Any questions at this point? Thank you. I think we're good.
Thank you.
And we will be looking at the bill again later this morning, and then hopefully this is a bill that we can act on relatively quickly because it is an important one. We have with us Sarah Teachout from Blue Cross and Blue Shield. Sarah, thanks for being here.
Thank you. Sarah Teachout, the Director of Government and Media Relations for Blue Cross and Blue Shield of Vermont. And I did submit written testimony to the committee that I think you have now. I will keep it brief. Blue Cross participated in the Essential Health Bench, the EHB study with the Department of Financial Regulation, and we appreciated the process and the thorough research that they did. Not only with hearing aids, but with the entirety of the EHBs. Blue Cross does not support or oppose adding hearing aids as a benefit, to make that clear. We do have one request. We request that you limit replacement of the devices to once every 3 years so that this benefit matches what the Green Mountain Care Board ordered for the individual and small groups in the QHP marketplace. So that's our only request. Just to comment briefly on the actuarial report, the actuarial analysis was specific to the individual and small group market. So it may or may not apply to the large group marketplace, which you're speaking of now. I don't know if the population is significantly different. And the actuaries were also looking at the cost of a hearing aid benefit in a typical year once this is underway. They did not include any costs for pent-up demand, which we believe is probably significant here in Vermont because there hasn't been hearing aid coverage. So we just want to let you know we anticipate in the first couple of years that this will cost more than the actuarial report. No reason not to do it. I just want to be very clear about that. So that is, I believe, the entirety of our testimony. The medical necessity piece is absolutely fine with us. And I can answer questions if you have them.
Thank you. That was pretty clear. And I think right now the bill does have the one for each year every 3 years. So it's consistent or not. I'm seeing your.
It does not. I've had a discussion with your legal counsel, and I have also talked to DFR. So it is clear to me that that is not in the bill. And I can forward you the responses I got.
Okay, that's good. We'll go through it with Jen in just a minute so we can clarify that. That's very helpful. Thank you. And just one more comment, and then Senator Hooker will have a question, and that is, I know you've sent us other comments about the pressures that we're all seeing in the healthcare system and included some other bills, but we're not talking about those today. And I really appreciate and respect that you haven't gone to the bottom of the memo, but we will pick that up going forward. So thank you. Senator Hooker.
Sure, thanks, Sarah. With regard to the 3-year replacement, we've asked before what that was based on, and I wondered if you had an answer to
that. So that was the original Department of Financial Regulation recommendation for the replacement cycle of these, and that's what the Green Mountain Care Board adopted in their order. And I believe it came from when we looked at other surrounding states, the replacement limitations they had ranged from, I think, 2 to 5 years. So that was what DFR decided to suggest.
As far as research on, how long these devices last or things like that.
Yeah, I'm not an expert in that, so.
Thanks.
Yeah, it's hard to predict, isn't it? When someone might need a different piece of equipment.
According to my sister, my mother lost 14 of them somewhere in her recline.
Oh.
That's an issue, especially
Yes, it is.
when you get into dementia.
Yeah, I know, replacement. Okay, any other questions now for Sarah? Thank you for taking the time and being here. And so what we're going to do now is we're going to ask Jen to come up and go through the bill, and keeping in mind the comments that we've heard today. And actually, I do have one question. I guess I can ask Jen this question. Do you know if the House committee took testimony from the VSEA or the NEA regarding their negotiated coverage? They have a different recommendation. they, your testimony on that.
So Jennifer Carvey, Office of Legislative Counsel. The House Healthcare Committee, I don't believe they actually took testimony. I think there was some communication with, not the union, but with the Department of Human Resources about the state employee plan, some communication with one of the administrators over there. I don't recall anything specific from on the teachers.
Okay, all right, well, we can track that down.
But I know the reason they were carved out, which I can
Yes,
report. And so they were carved out as I understand it because of the cost. There's, it would cost the general fund because they are publicly supported employees. So in order to avoid a cost to the bill, those were carved out.
but they already have a negotiated relationship, so $1,500 a year for each, for every 60 months, so,
Right, I believe
Yeah.
that's new coverage.
yeah.
It's recently added.
It was recently
Negotiated
added?
benefit. Yes, very,
Yeah.
very recently.
Okay, so suggesting that maybe we let that happen for a little while before we try to dive into it. Why don't you go through the bill with us?
Yes, and certainly it's a policy choice whether you include them or you don't include them. Just be aware there is.
Well, I mean,
cost.
if the analysis has already been done, cost, then I was gonna suggest maybe we ask for that analysis, but if it's already been
I don't
done,
believe it has been necessarily,
okay,
I mean, because of the new contract, I mean, I think it has been done for that benefit, which is a different benefit than the scope.
right.
So
Well,
it's
I
a
was gonna
narrower benefit.
ask to have the analysis done based on the benefit here as compared with what they have. And the committee's gonna have to decide if that's something you wanna do.
Okay, so section 1 of H266 sets out the purpose, and it talks about the effects, negative health outcomes associated with untreated hearing loss, expresses the desire that all Vermonters have access to hearing aids and related services, and it describes kind of what's going on with existing coverage and what the state is able to regulate and not regulate. So the state current Vermont Medicaid covers hearing aids. Most of the plans in the commercial health insurance market do not. As this committee knows, federal law either prohibits or preempts, depending on the particular plan, the state from regulating benefits in a lot of plans, including Medicare, that's a prohibited, and self-funded employer plans, that's a preempted. And Medicare does not cover hearing aids and related services, neither do most self-funded plans. Subsection B talks about the benchmark plan review that you have heard about and discussed with DFR and others. So just recounting that directive was made to DFR and others to review the benchmark plan and recommend whether to request federal approval to add benefits, including hearing aids. And that recommendation came back to look at adding hearing aids. And so last month, the Green Mountain Care Board approved a recommendation from the Department of Health, Vermont Health Access, to add coverage to the benchmark plan for up to 1 hearing aid per year every 3 years and an annual hearing exam. And so DEVA is working on pursuing a change to the state's benchmark plan with the federal government. That coverage for hearing aids and hearing exams would apply to the individual and small group market, and the date of coverage would begin on January 1st of 2024. So then subsection C describes the purpose of the bill being to ensure continued coverage of hearing aids and related services in Vermont Medicaid, affirm those ongoing efforts to make hearing aids and related services part of the benchmark plan. And then the new piece, make hearing aids and related services more accessible to Vermont residents by requiring coverage in large group insurance plans. That's the remaining segment of the commercial health insurance market over which the state has regulatory authority and which do not currently offer these benefits. So section 2 then is talking about the essential health benefits and the benchmark plan and requiring a report back from DEVA by November 1st of this year, and then update to the Health Reform Oversight Committee regarding the status of the department's application to CMS to modify the essential health benefits in Vermont's benchmark plan to include coverage of hearing aids and related services beginning in plan year 2024. Section 3 is codifying Medicaid coverage for hearing aids and audiology services, so making this an ongoing obligation that Vermont Medicaid provide coverage for medically necessary hearing aids and audiology services when delivered by a healthcare professional practicing within the scope of their license, including audiologic examinations, hearing screenings, fitting of hearing aids, prescriptions for hearing aid batteries, and other services as defined by DVA by rule. And that's really based on their existing rules, although this uses medically necessary instead of the specific decibel levels that they have, decibel level of hearing loss that they have in the current rule. Section 4 adds the coverage for hearing aids for the large group market. So we have the definition of health insurance plan as a group health insurance policy or health benefit plan offered by any of our insurer types, but does not include, so it's a group plan, but it does not include a qualified health benefit plan or reflective health benefit plan. So that's the small group. Since we're talking about groups, carving out the small group because they're being dealt with through the benchmark benefit plan. A health benefit plan offered by an intermunicipal insurance association to one or more entities providing educational services. So that is the teachers, and then it also does not apply to a plan or policy providing coverage for a specified disease or other limited benefit coverage. And we usually carve those out of coverage requirements because they're more narrowly focused on what their policy is supposed to cover. Yes.
Question, if the teachers already offer, have a provision, let's say it's the $1,500 every 60 months, would that already carve them out earlier?
So it's not the teachers that have the coverage, it's the state employees. I'm not aware that the teachers have any coverage.
My misunderstanding.
But this would just, regardless, this would carve out of a benefit mandate.
Okay,
That's really what it's carving out of. So they would not be required, but contractually they
they can
negotiate
still
all
go
sorts of
for it.
Got
Okay.
it.
So, Madam Chair.
Yeah, go ahead.
So paragraph A is the state employees paragraph.
Nope, A
Oh,
is
sorry.
the individual and small group market. So really for our purposes here, it's the small group market. So it just doesn't specify that it includes the state employees plan. Generally, we have to specify that we are including the state employees plan. They're not a commercial insurance product. They are a self-funded plan, but because they're a self-funded governmental plan, they are exempt from ERISA, and so the state can regulate them.
Okay.
But we generally affirmatively say that they have to participate, otherwise they don't have, they are not bound by insurance coverage mandates. That
Okay,
apply to the commercial market.
so because we're silent on it.
Because we're silent on it and we've not affirmatively included them.
Okay.
As I understand it from both CFR and DHR, they are not included.
And then B is the teachers.
B is the teachers.
And A is the small group plan?
A is, yeah, so qualified health plans are that's the name of the plan, the type of plan that is sold on the exchange and direct carriers. It's the individual and small group market is the qualified health benefit.
And we're excluding that?
We are carving them out because they are being dealt with through the benchmark,
Got
the
it,
change to
okay.
benchmark plan. And if you include them in here, then the state is required to defray the cost of the benefit
Got it, okay.
across the whole market.
And that's.
Never simple.
And that's the same explanation for C.
C is just there are plans out there that are for specified disease, like a cancer coverage plan, and they're much more narrowly tailored to providing the type of coverage that plan is for. They're not a major medical plan. So this is really saying, this applies to comprehensive major medical insurance plans. We're not looking at the narrow one-off insurance types, hospital insurance plan. And that's pretty standard in our insurance mandates generally. So otherwise DFR is reviewing the policy to ensure that it includes, for a major medical plan, to ensure that it includes all of the state's mandates. So they should be looking at the plans for the comprehensive major medical to ensure that they include hearing aids, but they're not looking for it in every type of health insurance plan that's for specific diseases or very limited benefit. All right, then we have the definition of hearing aid, which I can go through if you want. It's any small wearable electronic instrument or device designed and intended for the ear for the purpose of aiding or compensating for impaired human hearing, and any related parts, attachments, or accessories, including ear molds and associated remote microphones that pair with hearing aids to improve word comprehension in difficult listening situations in live or telecommunication settings. The term does not include cords, so you'd heard a comment about that. Large audience assisted listening devices, such as those designed for auditoriums, or standalone assisted listening devices that can function without a hearing aid. So there had been cords and batteries were both carved out in the bill as introduced. I think that was consistent with language in a number of other states, but the House Health Care Committee decided to include, and you'll see later on, that when batteries are prescribed, they would be covered under this coverage.
Okay, so go ahead. Cords for like rechargeable battery units.
I'm not clear on what the purpose of the cord, what they mean by cord. So this was language that I think had been modeled off language in other states, but I don't know specifically what is intended by it.
Maybe it's a cord that connects to some amplification system, I don't know.
Or a battery charge cord.
Yeah, or
You know,
that
like
could
what
be
you use
any-
to charge
yeah.
your phone. Yeah. It's just is a cord, and
Well, we'll get some clarity from our friends in the House, maybe.
I'm not sure they will know either.
They
You
will
may,
know- they will
no,
know.
you may want to consult with perhaps the either licensed audiologist or hearing aid dispensers
Okay,
to understand
all right.
just what I feel like you need somebody who really knows what the various parts are, and that
Parts
does
are.
not me.
We need to get a diagram.
I don't believe it's the.
We need to get a drawing, right? Okay, and if someone who is here with us today on Zoom, perhaps Ruby, you could help us understand why we would not be including cords, or if you know who testified on this.
There was no testimony that I'm aware
No
of on
testimony.
specific to cords in the House. It was language that was in the bill as introduced.
it was Rebecca who mentioned it.
Right, and Rebecca
did mention it. Okay, so Rebecca, maybe you could clarify for us in writing what the reference to cord is. And we won't,
And I can follow up with OPR as well.
yeah. And Rebecca, you want quick?
I did make my comment. I just emailed my testimony, and my understanding is the same as Jen Carby's. I think it's just kind of a historic relic copied from another bill, and I don't really know what it refers to either, so I thought it might be cleanest to just get rid of it.
Okay, well, thank you. That's also very helpful. Okay, and thanks for sending your testimony. Okay, well, we'll sort that one out.
Okay. Subdivision 3 is hearing aid professional services. That means the practice of fitting, selecting, dispensing, selling, or servicing hearing aids or a combination, including evaluation for a hearing aid, fitting of a hearing aid, programming of a hearing aid repairs, follow-up adjustments, servicing and maintenance of a hearing aid, ear mold impressions, and auditory rehabilitation and training. And the last definition is of hearing care professional, and this comes up because it's talking in the bill about who might be prescribing, fitting, and dispensing. So a hearing care professional is an audiologist or hearing aid dispenser, physician, physician assistant, or advanced practice registered nurse working within that professional scope of practice.
Can I just go back to the word cords? Without an H in it. So, I mean, if you think about some of these hearing aids that have
little tiny cords that go into the ear and connect with the ear. Could someone construe that as a cord, and if you broke the cord, you couldn't get it repaired? I was just like,
Yeah, I don't know. I mean,
I have
the
no
language
clue what that
in
means.
the regular definition without the exclusion part talks about related parts, any related parts, attachments, or accessories.
Right,
Yeah, it does seem like it's contradictory because a cord could be an accessory.
it could
And
be
so-
teensy.
I mean, maybe just taking it out makes it clear, because these
I
other
think-
things in this list are obviously big standalone kind of like
Right.
speakers and things that are clearly not hearing aids, but
That one is a problem. But can we take that word out? Would anybody be terribly upset? And I'm including people who are up on Zoom with us. All right, is anyone upset? Oh, good. Oh, thank you.
Take it.
All right, we have consensus. Let's get rid of that word.
Great.
We did a big, we did.
that was so huge. That was huge, Ginny.
We put our stamp on it.
All right, onward.
Okay, so then subsection B on page 5 requires a health insurance plan to cover the cost of a hearing aid for each ear and the associated hearing aid professional services when the hearing aid or aids are prescribed, fitted, and dispensed by a hearing care professional. And this is where the House added the coverage shall include hearing aid batteries when prescribed by a hearing care professional. Subsection C starts with the coverage provided by a health plan for hearing aids and associated services shall be limited only by medical necessity. And a covered individual may select a hearing aid that exceeds the limits in subdivision 1. So it's more than just what is medically necessary. Covered individual can select a hearing aid that's more than just what's medically necessary and pay the additional cost. The coverage required by this section cannot be subject to a deductible, co-payment, or co-insurance provision that is less favorable to a covered individual than those that apply generally to other non-primary care items and services under the health insurance plan. And a covered individual who has exhausted all applicable internal review procedures provided by the health insurance plan has the right to an independent external review as set forth in another section of this title. I think this would apply even if we didn't say it here. It's how the external review process works. But I think there had been some interest in including this when the bill was introduced in anticipation of potentially needing to use it.
So I'm looking at page 5 with B. Is that where we would put the 3 years?
So if you were going to do what,
Where would we put that?
if you're going to do what Blue Cross is asking you, I think you could either, you would put it in, potentially in, I might try to combine B and C together a little bit. Because I think you're getting a bit beyond, you're making the coverage less than just limited by medical necessity.
So it's
medical
less than
necessity.
medical necessity, so we've heard that we want to have medical necessity.
Right, so I think you're hearing two different things. You're hearing Blue Cross ask you to make the coverage align with the coverage that the Green Mountain Care Board has approved for the benchmark plan, which is 1 hearing aid per ear every 3 years.
Mhm.
And you're hearing from the advocates that they want to stick with medical necessity, which means the covered individual gets what they need when they need it, even that if that's more frequently than once every 3 years.
How can we cut the baby in half? How can we have medical necessity? So how can we have once every 3 years or through prior authorization when medical, something
I
like
mean,
that?
to me, if your hearing suddenly goes bad,
You gotta have it.
but what I don't think we want to pick up is someone like my mother who keeps losing her hearing aids,
No.
probably because she takes them out and puts them in her pocket when she doesn't
want to hear what's going on.
Right.
My grandmother did the same thing. If she wanted to hear what you were saying to her, she put in her hearing aid. If you lose them, and there is no consequence to losing them, this could get to be very expensive.
Well, that's what I'm thinking. So how do you put some precaution in there, like a prior authorization or, is that? Yeah,
Well, I'm just,
let me finish with a prior authorization or something that would say medically necessary. You actually need the hearing aid. We don't want people not to have their hearing aids. We don't also want to have people who are irresponsible about their care. Anyway, so go ahead, Senator Hardy, and then I see people with their hands up on the screen, and we'll take comments. We'll just have a discussion.
I guess I'm just confused if it's gonna be in the benchmark plan, the 3 years, that would apply to which plans?
Individual and small group.
Individual and small group, so it would not apply to Medicaid and
Medicaid is, if we're dealing with
Medicaid is totally separate, they have their own.
well, right, I mean, you
Yeah.
can, we're addressing them in here, but I wouldn't,
Okay, so it's just the
It's the
large
large
group
group
that
that
we're
we are
talking about.
talking
Okay.
yep, we're talking about, I think it's about 17,000 people, I think is what Ruby was reciting from Nolan's.
So if we added the 3 years in, if we did that, then the large group and the small and small group would have, individual group would have the same, it could, because the small and individual would be the benchmark.
Well, they would have the same because you would be making the large group align with what's in the benchmark.
That's what,
Right.
yeah. And related to the benchmark, do you, this, you might not know this, but for teacher and state employee plan, do they do anything that sort of tags their coverage to the benchmark, or is it totally
No,
separate?
it's separate. I believe the state employees plan may have there are certain things that they have to align themselves with a benchmark plan for purposes of what constitutes essential health benefits to determine whether annual and lifetime maximums can apply and things like that, but that's getting a lot more nuanced than I think we're looking at here. So generally, no.
Okay, so I'm gonna look up, I see Ruby, you've turned your screen on, and Sarah, you've turned your screen on. You want to comment on our discussion? Because it would be helpful for us to hear your thoughts. So Sarah, go ahead.
Thank you. Sarah Teach Out with Blue Cross. We're asking for replacement to be limited to every 3 years, nothing by medical necessity. So a person could have their medical situation change. I'm thinking about children who grow. And then under medical necessity, they may need a different type of hearing aid, and we fully anticipate covering that. Or if someone whose hearing condition changes, worsens, and needs a different hearing aid, we also anticipate covering that change. What we want to prevent is this replacement of the identical hearing aid more frequently.
Your mother, the Senator Cummings'
Just gonna write
mother.
Senator
Okay.
Cummings' mother in the motion.
All right, so my husband. All right, so
And I think I can offer a little clarity on the VHI and state of Vermont plans, because Blue Cross does administer both of those benefits. So VHI currently has no coverage for hearing aids, and the state of Vermont Union and Human Resources Department negotiated hearing aid coverage that will begin this July 1st. And it's true, they do have the $1,500 cap per device per ear, and in every 60-month replacement.
okay, all right, so, okay, Ruby, do you want to comment on what we've been talking about, and in particular what Sarah Teach Out just mentioned? So they're not interested in replacement, but rather if there's a medical necessity for change within the 3-year period, that would definitely happen. Go ahead.
I just wanted to say that under the essential health benefit structure, 1 hearing aid per ear every 3 years, if somebody needed it more frequently for a medical reason, they could their hearing care provider could go through the prior authorization process to make that happen sooner. But this committee has heard a lot of testimony about the administrative burden of prior authorizations, which is why medical necessity skips that. I don't.
If it were medical necessity, not prior authorization, that would be acceptable.
We support medical necessity. Yeah.
And so does the Blue Cross, right?
Yeah,
Well,
so
it sounds
Blue
like Blue Cross does support medical necessity, but with replacement once every 3 years.
Replacement is,
So what can we do?
Maybe find replacement.
So, right,
so
so,
how can we clarify
so
that?
we can put something in on that, but I didn't know if you wanted to hear from Ruby about their position on the replacement once every 3 years. Or,
Ruby, so we heard your statement on medical necessity and having it be maybe more frequent than once every 3 years. What about replacement as prior authorization or?
well, no, once every 3 years.
Once
I think.
once every
Let's not
3
put
years.
any prior authorization.
No prior authorization, forget I said that, I'm thinking of something else, okay.
So we would like people to have hearing aids who need hearing aids. And they are financially burdensome to many people in the $3,000 to $5,000 for a set of hearing aids. So personally, and I think the coalition will support this. If somebody has had a hearing aid for a year and a half and loses that hearing aids, we don't feel that they should be financially burdened or penalized for needing a new hearing aid. But I don't have any statistics on how frequently the general population loses their hearing aids. And I would just also recognize that many people with Alzheimer's and dementia are on Medicare, which is not any part of this bill. So this bill is really talking more about younger adults in the 65 and under range. And so I think the risk of loss is probably lower than what you're fearing.
Okay, so can we summarize what we're hearing here then? Are we hearing that one replacement for each year every 3 years, one replacement once each year every 3 years?
So not,
But if there's a medical necessity, then a new type of hearing aid or some kind of upgrade can take place. That's what I'm hearing.
well, I think that's what you're hearing from Blue Cross.
That's what I heard from
Words in
Blue
a row, I think you're hearing from Ruby that they don't want limitations on replacement. If somebody needs a replacement hearing aid, they're concerned that the person would have to wait through the rest of the 3-year period before they would be able to receive another one.
Finance. We found out time and time again, it's like Jell-O,
Yes.
that this is a new coverage. We don't know what it's gonna cost. We know, especially if you get into the exchange and the benchmark plans, that if it costs more than we anticipate, the premiums are going up, which means that some people won't be able to afford premiums, it's.
Right, this is
always
just
that
large
number.
group that you're looking at right now.
That's just
Just
large group,
experience
but
rated large group.
Just what?
Experience rated large group. It's not community rated, doesn't spread
Right,
across everybody.
right.
It's just for each employers.
that are not
Not self-insured,
self-insured.
small group, individual.
It sounds as if Blue Cross agreeing that, people can have their hearing aids replaced due to medical necessity, for a medical necessity.
Yeah.
That just generally speaking, okay, we've taken 3 years as opposed to 2 or 5, and kind of split the difference. That seems reasonable, as long as people can get the hearing aids that they need, when they need them. My question, that being said, if somebody loses a hearing aid, the medical necessity for it is still there. So is the insurance then going to cover the replacement?
Sarah, there's a question for you. If someone loses a hearing aid, before their time is up, the hearing aid's time is up, then they still have the medical necessity for the hearing aid. How would Blue Cross and Blue Shield handle that?
Right. So you're asking a hypothetical question because none of our customers currently have hearing aid coverage in their plans. So we have not yet drafted the policy. But my anticipation is that this would not replace lost hearing aids more frequently than every 3 years.
Got it. Okay. All right.
And I don't think they fall out a few years.
Well, we can discuss that at some point, but it depends on the individual. Ruth, you want to comment?
Yeah, I mean, I
Sorry.
think I'm torn on this, but I think an argument could be made that what we're hearing from testimony, just sort of generically or generally speaking, is the desire for equity across all
Yes.
coverage. And if the benchmark plan is the medical necessity and every 3-year replacement, then one could argue that the large group should be medical necessity and every 3-year replacement, and that's equity across all 3 plans. And is that right? I mean, not your opinion, but like, is that?
Yeah, no, I think,
Yeah.
right, I think I'm not gonna get into what's equity and what's not, but I think
Right.
we're talking about the idea of aligning the coverage,
Right.
making it be the same. And I think, and for me, in order to understand the nuance of how they're thinking about the medical necessity plus replacement for the benchmark plan, I would just want to talk to
Yeah.
Diva and DFR to try to get the language the same.
Yeah, so I think that we can make the argument that we're just trying to align. I like alliance, that's a good term.
We love
We
alignment.
want to align the coverage
My favorite word.
for all 3, for the small group, the individual, and the large market. And that would be doing what the Green Mountain Care Board. And then we don't have to get into the whole argument of whatever, and that
Give it a
is-
chance.
give it a chance, and that, the foundation of it is medical necessity, and that, a doctor can make the argument for medical necessity under a whole slew of circumstances. But on the whole argument of alignment, I am a little uncomfortable with the teachers and the state employees being not aligned. And I understand that they have negotiated plans, and I understand that there's, a potential general fund implication for the state employees, and certainly school budget implications for the teachers. But we didn't hear any testimony on it, and I thought I remembered, but I'm clearly not. I thought I remembered there was something like that we couldn't require it because it was up to negotiation.
Yes,
Do you remember
yeah.
hearing that?
No.
So that was
Because
my
state-
impression, but
You
maybe
can,
it didn't.
the legislature, legislature you can pass laws that require them to provide certain benefits, and then they negotiate the impact.
Can
So
we,
we
So
could
it had to
do,
be prospective, I mean, you couldn't.
go ahead.
right, I was just gonna say, maybe we could say something to the effect of, for the next negotiated agreement, we
To consider,
that you should align hearing aid coverage with
consider
these.
alignment with.
Yeah.
I don't think we can tell, well,
Can't
if we tell them that it's
You can
done.
tell them.
Yeah,
You can tell them.
We can tell them to align for the
guys
next
are really-
one.
Okay, good.
So it wouldn't be for this current one, we wouldn't go in and mess with what they already did, but it would for the next one.
Okay, except we run into the general fund.
Right, there will be a
Issue.
cost.
It costs a lot of money, so before we say go do it, maybe what we should be asking for is an evaluation of the cost first. And so otherwise it's gonna cause,
How long is this agreement with the state employees?
Annual.
Oh, Sarah might know.
Sarah, do you know how long
Two
they,
years, I think.
Yes,
years.
the state employee agreement goes to, if it starts this year, is it a 2-year agreement?
I don't know if how frequently they adjust the benefits.
Okay.
Okay, having just tried to take parking spaces away from firefighters.
Taking what away?
Parking spaces.
Oh.
That was part of a negotiated agreement 40 years ago, and they took less than a pay increase to get that privilege. If we, I mean, this is all, again, you may find out that they don't get the pay increase in order to cover the coverage of hearing aids. They might not be happy if we did that to them, or they might have to give up some other coverage that they might not be happy because.
And that's bargaining the impact.
Yeah.
And so
They say, well, these are the ones that
stepping
we
into
have-
the whole negotiated
These are the ones
agreement
we have
process.
to, and
And you can bet the union is gonna say everybody else gets hearing coverage. It'll be part of it, because everybody else is getting
Right,
it.
and they have added it as a benefit
Right.
beginning in July.
Start.
I wasn't sure about the
So
start. date, that's all.
I'm feeling that, well, this is a great suggestion, that there are a lot of barriers in the way, and if we want to, we could spend a great deal of time taking testimony. So I'm thinking that let's put this one on the back burner for right now, and then let's think about if there's anything we want to say. Think about what.
And the other one is the teachers. We
Well, the
just,
two of them.
yeah, but we just went to a statewide negotiation for teachers. And that's a thing that's near and dear to the administration's heart.
We
Could
have-
inspire some big black tents to come out. And we just, I don't know what it would do to the pension agreement, but we know we have been severely underfunding their healthcare system.
That's
Yeah.
the retirees healthcare.
No, it's what we're putting in now, the annual cost. Employer's annual cost is going on your property tax, and we have picked up over $40 million in additional pension costs on the property tax in the last 2 years, so
Well,
that's where it's gonna show up.
So do some thinking on this one. If there's any language that we want to put in that would direct some analysis,
Considered. Just remember our motto.
yes, it's right behind Ruth. That one, and then also we have a significant stack of requests in our committee, and this one would just be a hugely heavy lift. And it will slow the bill down, it must be, you know, so I'm thinking from a practical point of view, let's just think about this overnight, we'll come back to the bill tomorrow, because I'm hoping that we can act on it in some way. We've made a change, we took boards out.
well, we also did the other one,
And they did the other one.
right?
That's
So
gonna get us into committee process.
we did that, right?
Yeah.
Well, I guess, yeah, I mean, I think we should sleep on it, and, we haven't heard nobody's come to us on from either side saying
Nobody
do or
has
don't do
Right.
this, so.
We haven't,
Besides,
Well, that's because we haven't told them we're gonna touch it.
this is the first time we've heard about it.
right, so if we can,
GSEAs are saying, you know, they have negotiating conditions. And I think that they.
Oh, we have heard that?
I heard.
We haven't had any
On other issues, you know, as far as negotiating.
Oh, just generic.
we'll do a little bit of that. We'll
look
try to
into
bump into VHI or VSEA folks and just ask whether they're even thinking about this at this point. So Jen, what do we have now we have our two,
Yes, I'm just emailing to them.
Yeah, okay.
So yes, you're taking courts out and you're looking at aligning.
alignment,
Yes.
that's. Well, I'd be thrilled to see people accessing hearing aids in a way that they haven't been able to in the past. Just really terrific, and there's an opportunity then to get some data back and understand the effectiveness of this. Should we put something in there asking for the outcomes? Not too much to ask.
Asking for outcomes of what?
What we're doing, you know.
What costs?
Are we seeing a benefit? Are we seeing people accessing this benefit over the next 3 years?
Well, yeah, but that's not, to me, and yeah, they're gonna use it.
Right.
The outcome, which is a lot more complicated, is there a benefit? Is, do they do better in school? Are they more successful?
Are there fewer falls?
That's
That's
whole
another,
graduate program.
that's another one of those.
Yeah.
Right, okay. Okay. Well,
You know, any graduate students, that would be good. That would be a research project.
All right, so I think at this point, we have solved most of our problems. We still have some outstanding thinking to do. We'll come back to the bill tomorrow with the 2 recommendations that Jen will have for us. And we'll try to, each of us talk with folks regarding the BSE and BSEA and BPI issue. So Aaron, I think we're ready to go off YouTube, and